Hello and welcome to our latest webinar in our series of Known Unknowns. I'm Kamran Abbasi, Editor-in-Chief of the BMJ. Welcome. I'd like to welcome you all to this webinar. Our Known Unknown series has been going for, 2 or 3 years now, and we really, we're very grateful to Alison Pollock and George Davies-Smith for establishing this for us. And we really try to address uncertainty in medicine. I think there's a great deal that's talked of with certainty, as if there's no doubt, there's no debate. But as we know, much of medicine and health is open to discussion, open to debate, and there's lots we don't know, and lots that we're trying to understand better through more research and through more conversation. So that's our ambition for the rest of today, for the next hour or so. And the topic for today is ADHD, attention deficit hyperactivity disorder. And we'll be looking at various aspects of ADHD. We'll be thinking about what is ADHD. We'll be looking at the influences on diagnosis. We'll have a summary of the evidence on drug treatment. We'll consider the potential, the role and the potential of psychological therapies. We'll talk to somebody with lived experience about being diagnosed with ADHD. And we'll as well, I think rather kind of topically, look at the impact of social media and self-diagnosis. So we do have a packed session for you. We'd like you to participate. We've already had questions, so that's great. And we're putting those questions to our panelists today. But do keep sending your questions and do send them in through the Q&A function that you see on the Zoom conference that you're on, and do introduce yourselves using the chat function. So introduce yourselves using the chat function. Any questions for the panel, do send them to us via the Q&A function that you see before you. And the webinar it's going out live, but it also will be available on YouTube shortly after it's finished. So let's get going. And I'd like to just say hello and welcome to our panelists. If they could just appear on screen to say hello. We have with us Anita Thapar. Hello, Anita. We've got Stephen Hinshaw. We've got Daniel Gorman. We have Edmund Sonuga-Barke. We have Kirsty, and then we have Elia Abi-Jaoude. So welcome all of you. I've also got Alison Pollock with me, one of the originators of Known Unknowns, to help with some of the questions and the comments that you're sending in. Okay, right. Without further ado, let's go to our first session, which is with Anita Thapar. Anita is a clinical professor and honorary NHS consultant at Cardiff University. So welcome, Anita. Good to have you with us. If the others could leave the screen to Anita, that'd be great. Anita, you're going to take us through the history of ADHD, well, some of it at least, and talk about the epidemiology and help set out some of the known unknowns. So thank you.
Thank you. Can you all see my screen?
Yeah.
Right. So these are my disclosures. All my salary comes from Cardiff University. So I'm going to start with, how is ADHD defined? So in clinical settings, we use two main diagnostic classification systems. One is the WHO ICD-11 currently, and in the US, the Diagnostic Statistical Manual of Mental Disorders, DSM-5, is used. They're broadly similar in their definitions. To reach a diagnosis of ADHD, you need multiple symptoms of hyperactivity. So these would be symptoms such as excessive fidgetiness, multiple symptoms of impulsiveness, for example, constant interrupting, and multiple symptoms of inattention, for example, failure to pay attention to detail. It's not enough to have multiple symptoms. The current classification systems require that problems start before the age 12. And it's also not enough to have them just at home in one setting. So for children, we will also require problems in school. And for adults, typically that would also be in work. That's still not enough to reach a diagnosis. These symptoms also have to interfere with day-to-day functioning. So for children, that could be with peer relationships, getting on with social relationships and their family. And for adults, for example, it could be managing day-to-day tasks. So for clinical reasons, we need to know whether someone has a diagnosis or doesn't, a yes-no decision, because so many of our clinical decisions are yes-no. For example, do I accept this referral or not? Do I use medication or not? Do I use treatment or not? These are all yes-no decisions. But actually, there's a lot of research in epidemiology and other research areas showing that there's a continuum of ADHD in the population, with everyone having some symptoms. It's a bit like blood pressure, if you like, with those with diagnosis being at the high end, at the top end. I always think it's interesting that multiple research studies have shown that with this continuum, that the risk of adverse outcomes is across the continuum. There isn't a definite cut point at which disorder appears. Again, similar to blood pressure. And I think it's interesting, the threshold for treating high blood pressure today is different to what it was when I was a medical student. A lot of people think ADHD is new. It's not. It's been described for centuries, and in the medical literature was described by a Scottish physician in 1798. And the first sort of medical publication was published in The Lancet by a British paediatrician, George Still, who described a case series. The current classification systems really came in the later 20th century, and moving from ADD in the US to the current concept of ADHD. In all the classification systems now that we use, ADHD is grouped as one of the neurodevelopmental disorders that are similar in that they onset in early development and involve early brain development differences. So these include conditions such as autism spectrum disorder, language problems, learning disorders such as dyslexia, intellectual disability, and motor disorders. All these conditions show massive overlap. So ADHD shows overlap with them, and also a higher than expected risk with epilepsy. So a lot of people think surely ADHD is a Western and modern problem. And actually there's been a lot of research done here. So when you look at populations, we're not talking about clinics, just in the population, multiple studies have shown that there aren't clear-cut differences across countries, even when you look at non-European countries. What about when you look at population data, which has been done across different time points? Well, again, at least for children, there is no change in the ADHD symptom levels. And I think what's interesting is that very same comparison research has shown increased levels of anxiety in children, but not ADHD. So why have clinic referrals increased if symptom levels have stayed the same in the population? And it's really uncertain as to why this is. Well, one issue that we know is that there's increased recognition. Of course, everyone's much more aware about ADHD, and also aware that ADHD also affects adults. Children don't grow out of it. Females were previously very much under-recognized, so this is one reason. The other possibility we have to consider is overdiagnosis, because under and overdiagnosis is not uncommon in medicine, for example, for epilepsy and asthma. Both issues have been found. But actually for ADHD, and certainly in the UK, but quite a few countries, the rate of ADHD in clinics is less than it is in the general population, i.e. we're not picking up everyone. So there isn't a clear-cut evidence everywhere. But of course, I think Steve may talk about some exceptions, certainly not in the UK. One possibility that clinic referrals might have increased comes from some research done on children, again in the population, which showed that over time, whilst the symptom levels of ADHD haven't changed, today there are greater impacts on learning and distress in children as reported by parents born more recently compared to 30 years ago, which of course would also then drive referrals if there's greater impacts of the same symptoms. What causes ADHD? There's a lot of speculation about this, but actually the genetic research is really robust across multiple different countries. ADHD runs in families, and there is actually a really strong genetic influence on ADHD, like autism and schizophrenia. I think it's important to recognize that not everything is very strongly genetically influenced. For example, anxiety is not. There's been multiple lab discoveries, again, through international collaboration, and it isn't just one gene, which is of course true for most common conditions we see in medicine. For example, like diabetes and heart disease, there's thousands of genetic variations of each of small effect size, which increase the probability of someone then having ADHD. However, there are some rare types of genetic variants which occur in less than 1 in 100 people, and they have a much larger effect size, like, for example, chunks of DNA missing or extra. And those sorts of gene variants have been found to be much more enriched in people with ADHD, also in autism, also schizophrenia and intellectual disability, but not for mental health disorder, other types of mental health and brain disorders. The other thing that's really popular is people believe that ADHD must surely be explained by social adversity. And quite often people think, oh, it must be the parents, because they might just look at people with ADHD and people without and find maybe more family stress, for example, or different styles of parenting, and people assume that must be a cause. However, you have to be really careful about assuming that, because of course, having a child with ADHD also has impacts on what happens in a family. And actually quite a lot of research has shown that children with ADHD, their relationships improve after they've had treatment. So this opposite direction is called reverse causation. So you have to always use research to look at that, which isn't always the case that people do that. The other factor is that it could be a third factor that hasn't been measured that's resulting in what people think is a cause, for example, something about parents or some other social factor, and also which influences the child's ADHD. So again, you need research that really measures whether it's possible that this link is due to a third factor. So we have to be careful about thinking something is a cause. So are there any robust findings on non-genetic causes? Well, one finding that there are two, I think, that stand up to rigorous tests. One is preterm birth, being born too early, because that has been shown no matter the relationship, why people get born preterm is very different in different countries, but it's associated with ADHD everywhere. And the other is work conducted by Edmund, who you'll be hearing from later on, who found that children who were exposed to extremely rare deprivation of the extremity that we wouldn't see typically with the Romanian orphans, they also showed autistic and ADHD-like features. The other thing is people think children grow out of ADHD, and the evidence here is not the case. So again, that is why we're also seeing much more in the way of adult ADHD and services. So the majority of people continue with symptoms, and some people will develop other problems. So, for example, depression, substance misuse, self-harm, suicide, more serious mental illnesses such as bipolar disorder and psychosis. And whilst we haven't got long-term treatment trials, there's some naturalistic studies that look at people when they're on and off medication, suggesting that might help reduce risks. It also has been found to have an impact on education, employment, earnings, as well as physical health and premature mortality. However, just want to emphasize there is huge variability. Some people are very badly affected, whereas others really, with proper support, thrive, do well, do medicine, do PhDs, and can really excel. Treatments are not well tested. That is not true. We'll hear about that later. There are high quality treatment trials in the UK. We start with psychoeducation, school and work support, lifestyle management, and then added medication. For adults, talking therapies can be a useful addition, but the long-term benefits that we'll hear of medication have been hard to show. So, summary, it's well recognized, well researched. There's increased recognition and referral. It really requires a careful assessment. You can't just diagnose ADHD, not because it is a continuum, but you've got to balance risks versus benefits, particularly if you're thinking about medication, of having a label. we can't ignore it because there are multiple ADHD adverse impacts and costs. That's been showed widely. And you have to be a bit wary of what you read because there's so many myths and misrepresentation not grounded in research.
Anita, thank you. An excellent start. Thank you very much. One question for you from me, which is, you talked about the greater impact today on learning compared with in the past. Why is that?
We don't know. This was a simple observation to suggest that. There is also some preliminary evidence suggesting maybe mental health outcomes today may be worse, which of course would then drive up referrals. So at the moment it's speculation, but with anything, and ADHD as well, you might have something which is innate, but the impact of it will also depend on context, like your schools and how much, how much flexibility you have, what are you supposed to achieve, what are the expectations. So whilst there may be a biological contribution to symptoms, the manifestation and its impact will also vary by social context.
Okay. I mean, I was a little surprised you're reasonably definite on the fact that it isn't overdiagnosis, it's increased recognition. What's the evidence around that?
Okay. It is variable by country, and maybe Steve will say something about it, or one of my other colleagues, but consistently in the UK and many European countries, studies have looked at there's been multiple studies done of the prevalence of ADHD, epidemiological studies done in the general population, using diagnostic interviews, what's the prevalence rate, and then what's the administrative rate, the rate that's being picked up in clinics and is being registered, in clinics. And actually so far, I'm not saying it will stay like that, it's been less than the true prevalence to date.
Okay. So
that it's inferred from that. But as I said, it will vary by country to country and even within countries.
Yeah, by setting. Yeah. I'm going to just bring in Alison. Alison, are there any relevant questions at this point for Anita?
Well, there are a few which may be picked up later as well, but one of the ones is, Anita, is there a connection between ADHD and autistic spectrum disorder? That's a question that's quite often asked.
Yes, there is. It's interesting because until 2013, the official US diagnostic classification and also the WHO did not allow co-diagnosis of ADHD and autism. However, most clinicians recognized that they were actually ending up, they had people with both. And the diagnostic classification systems have now removed that because there is a very strong overlap. So people with autism are at much higher risk of ADHD, and people with ADHD are at much higher risk of autism, with many shared risk factors. So they're like cousins. And also that, like you could have, because of the shared genetics, you could have one child with ADHD, the second child with autism.
Interesting comment. Thanks, Anita. Cameron, there's some interesting comments coming in from our Canadian doctor saying in her Canadian practice, she's yet to see anyone not receive the diagnosis who wanted it, and she's worried about the explosion of adult ADHD clinics who do extremely quick assessments.
Okay.
There's another maybe that's picked up later, but there's another question about children. Should the referral be made through schools or through the general practitioner?
Okay. Anita, do you want to respond to either of those two? And then we'll move on to Stephen.
Very quickly, two things in terms of referrals. Well, at least in the UK, it will vary by area to area. In most of our areas, we take from either. There are routes for both. The second issue in terms of Canada, I would leave that to my Canadian colleagues. At the moment in the UK, within the NHS, we don't seem to have overdiagnosis, but as I said, that might change as we have, increasing pressure with privatisation. I don't know. But as I said, I can only go by research to date.
Okay, I think this conversation probably will be continued.
Yes.
Thank you, Alison. Thank you, Anita. Let's move on to Stephen, and we'll have Anita back at the end when we take panel questions. We've got Stephen Hinshaw. So we've heard a little bit about the cause and the prevalence of ADHD. Let's talk now more about the diagnosis and what might trigger a diagnosis. Stephen is Distinguished Professor of Psychology at the University of California at Berkeley. And he's written extensively on ADHD and diagnosis, and he's going to give us a quick tour through the social and cultural influences on diagnosis. Stephen.
Thank you very much. I'm going to get my slides up. So I'm going to make a few comments on, let's see, rehearsals. So in just a very few slides, I'm going to talk about a couple of social and cultural influences on why, at least in some countries, diagnostic rates may be going up. In the United States in particular, where they've gone up quite dramatically over the last several decades. And I'll talk about a couple of potential influences. One, direct-to-consumer advertisements. Second, school policies that have my colleagues and I have shown have fairly dramatic impact on who gets diagnosed in which regions or states in the United States. And getting back to a question that's been raised and a point that Anita made, what about quick and dirty assessments? Does everybody who comes into a clinic get diagnosed with ADHD, whether a child or an adult? And then we can discuss greater secular trends. But I've only got a few minutes, so let's keep going. Direct-to-consumer advertisements have been allowed for some years in New Zealand and in no other country, except in 1997 and 1999, the United States FDA, after some fairly careful study, said it might reduce stigma, and it would certainly reduce prices because of competition and advertising for pharmaceuticals. Whereas before you would lose your medical license, et cetera, if you were part of an advertisement in anything other than a medical journal. For the last 24 years, they've become quite commonplace in the US. And it's a multi-billion-dollar a year industry, advertising for medications in the popular press. So, because I'm not in presentation mode, I'm going to go advance my slides as carefully as I can. So under the doctrine of fair use, I don't work for pharma. I have no disclosures to present to this audience today. But I'm allowed to show a couple of sample ADHD medication ads to talk about their meaning and content what's under, again, the doctrine of what's called fair use. So here's an ad for Concerta. This came out about 21 or 22 years ago. Concerta was regular old methylphenidate, trade name Ritalin, put inside a space age plastic configuration that would gradually squirt out the Ritalin, the methylphenidate, over 10 to 12 hours rather than the usual half-life of 3 to 4 hours. So it was the first documented to be really effective long-acting form of ADHD, quite popular with parents and schools because the kid wouldn't have to go to the school nurse. There's no more school nurses in the US anyway, and to take the medication or forget to take it, etc. So in this ad, we can see the stereotype of ADHD for a long time in most countries, especially the US, was this is a white middle or upper middle class phenomenon. So here we see the white smiling mother and her white son. Looks like he's just got his permanent teeth in, so he's probably 7 or 8. And not going to go too long on this, but the content is the mom says, when Jason gets his medication, I see the real boy. I don't see those annoying disruptive symptoms. I see who he really is inside. So if you don't go too far in interpretation, this may be in the ADHD medication ad land, the first implicitly anti-stigma message, that medicating your kid with ADHD removes the stigma and the bothersomeness, allows natural family interactions and natural development to occur. Now, whether that's true or not is a huge question. but it's hard to doubt that it's a very powerful message. So next up is our next ad. Let's go this way. I'm sorry to be slow with this, but I can't quite get it into presentation mode. And so here's an ad from several years later, and obviously the target here is adults with ADHD. And if you have really good eyesight, you can see that the pharma company says, with citations to psychiatric literature, if you have ADHD as an adult, you're about twice as likely to get divorced as neurotypical individuals, and about a third more likely to get major depression. And if you don't study developmental psychopathology, or you're not trained in critical thinking, it would be very convenient for an adult reading such an ad to say, I'd like to stay married and I certainly don't want to get depressed, so I should take ADHD medications. Again, a pretty powerful message. And by far the fastest growing market in the US, and I'm sure in Europe, is for adults with ADHD. The baseline has been low. Medications have not been studied for adults with ADHD in the last couple of decades, and now that market share is rising rapidly. So here's our third quick review, ad in our quick review. This is American baseball. This is Shane Victorino, the first Hawaiian American to play Major League Baseball, 2 World Series championship rings, power hitter, and he teamed up with 2 national advocacy groups in the US and 1 pharmaceutical firm to present a series of commercials and print ads. And as you can see, this ad is a quote from him. "I didn't outgrow my ADHD," Shane says. "That's why I'm telling my story." So it's a powerful anti-stigma message. And in other ads, he and his beautiful wife and beautiful children are doing outdoor activities. And it's, boy, if a power hitter like Shane Victorino can admit to ADHD and take medications, perhaps so should I. There's a bit of a backstory here. There's another reason why he is telling his story, which is that in the United States, if he were taking a stimulant medication for ADHD without an exemption, without a medically certified diagnosis, allowing him to take ADHD stimulants during games, he'd be a kicked out performance enhancement, just like steroids. He'd lose 81 games out of the 162 game season. Now, I find it interesting. I should update my data, but from not too many years ago, I looked up the statistics, and about twice as many Major League Baseball players in the US had ADHD exemptions, as did National Football League, National Hockey League, NBA. And there is a perhaps fascinating epidemiological story about why ADHD would cluster in baseball players, but there's a much simpler explanation, which is that baseball may be the most boring sport ever existed, invented by humankind. And long games, they've tried to speed them up this year, 4 hours, and the 9th inning, the sun is setting, the mist is coming in. You've got to be very alert for that hanging curveball, or you've got to be very alert for that line drive sinking in front of you out in left field. So this is part of the controversy about ADHD, and perhaps a fueler of diagnosis, overdiagnosis, overtreatment. Maybe people are gaming the system, finding the right diagnosis to get a performance enhancing medication, whether for school or for work or Major League Baseball. So that kind of ends our series of ads. And to make a comment or two, so was the FDA right? Does the showing of such ads to the general public reduce stigma? Hard to know, hard to randomly assign a segment of the population to see such ads, and hard not to. Maybe it's good for people to see on TV late night, or read in a TV Guide magazine or Ladies' Home Journal about these diagnoses and be able to talk about them? Or does it convince people that they must have a condition that they don't, and they're going to find a doctor who will give them that diagnosis? Do these ads reduce prices under the idea of competition? And the answer there is an extremely clear no. No pharmaceutical company in the United States publishes these ads once the medications have gone to generic and the patent protection is lost. the ad revenues stack up during the early years of the release of a new medication when there's essentially no competition. So clearly that kind of economic argument, although it sounds good on paper, is not being borne out. How many of these ads emphasize the common finding in the literature that when you combine the right dose of medication with organizational skills or family behavior management or CBT for adolescents and adults with ADHD make a big difference? Absolutely none of them, because they're not out to sell psychotherapies or psychoeducational interventions. And finally, how many pharmaceutical companies in the US who produce and promote ADHD medications have been fined for misleading ads? And the answer is every single one, on the order of several $100,000 to multiple tens of millions of dollars for misleading information and miscitation of the literature, et cetera, et cetera. So I'm not saying that direct-to-consumer ads are the bane of existence. It looks like New Zealand may be reconsidering its policy on that, but it's certainly part of the zeitgeist that people with ADHD may not know they have it, and they see advertisements and they get a diagnosis, maybe even an online TikTok diagnosis, and seek doctors who will prescribe medications. So I talked about a lot of this in a book I wrote with Richard Scheffler, my health economist colleague here at UC Berkeley, The ADHD Explosion. And we pursued another topic in the ADHD explosion, which was rising rates of diagnosis in the US. And I don't have time to go through this slide. These data are confirmed up through the next wave of the National Survey of Children's Health, that more and more kids are being reported by random subsamples of 100,000 families surveyed every few years. The families are saying, yes, my child has received a diagnosis of ADHD, or a healthcare professional has told me that my child has ADD or ADHD. So the rates are going up at fairly intense rates overall. But more important for our argument was that the rates are going up very disproportionately across US states. So if you're good at geography, you'll see that the highest rates of ADHD diagnosis back in 2012, this is pretty much confirmed with the data 6-7 years later, although I don't have the map for it handy today. In the South and Midwest of the US, there's about 3 times the rate of diagnosis of ADHD officially than in the plains or the far west, California, Nevada, out where I live. In fact, in spot your geography here, Indiana, North Carolina, and Arkansas, the 3 highest states, if you were a boy over the age of 10, the chances that you've had an ADHD diagnosis in your lifetime were upwards of 30%, not 3%, not 13%, but 30%. So there's a huge disparity in certain regions of the country having ridiculously overdiagnosed rates of ADHD. And again, in the plains and far west, they were pretty much at the world averages that Polanczyk and his colleagues have shown in several meta-analytic reviews of world diagnostic rates. So Richard Scheffler and I looked at the demographics, the proportion of ethnic minority, racial minority kids, didn't explain anything. What about the numbers of child and adolescent psychiatrists or pediatricians in these areas? Didn't explain any variation at all. What about California, where rugged individualists, and in the South, it's a culture of honor, and I could make up anthropological stereotypes, but they don't explain anything. But then Scheffler and I, who join each other's lab meetings, he told me early in our collaboration that once I gave a talk saying that the cause of ADHD was compulsory education. And from Anita's slides, it took the Enlightenment and the Industrial Revolution for medical recognition of what now has become ADHD. Maybe having kids sit still in school and do things the human brain never evolved to do, like learn to read, elicits, and I was saying causes tongue in cheek, but it elicits or uncovers or reveals the genetic variation, and the kids who have the most trouble with self-regulation are the ones who get diagnosed. So how could we test that hypothesis? Long story short, the United States for the last 40 years has been very concerned about its reading and math test scores in public school kids. Every district has to do these massive tests several days every spring. And in the 80s and 90s, 30 of the US 50 states passed laws saying that if your district didn't get its test scores up to a certain level, or if the change weren't big since the last year's assessment, you'd lose funding or maybe even lose control of your school district. These are called consequential accountability laws. There's consequences and accountability for school achievement. And then when George Bush II barely became president of the United States in 2000, the first piece of major domestic legislation he got through was something called No Child Left Behind, which was to boost reading scores around the country. It had nothing to do with ADHD, but one of its provisions was that consequential accountability now suddenly applied to the remaining 20 states in the US. To make a very long story short and cutting out a slide or two, if you were, and we hypothesize that the effects on diagnosis would be right for the kids at the federal poverty level in the United States. In this blue line at the top, and by some miracle, the timing of No Child Left Behind and consequential accountability timed exactly to the National Survey of Children's Health, first ever national survey of diagnostic prevalence of ADHD in the US. A 60% increase in diagnoses in the US for those states that suddenly had No Child Left Behind legislation compared to the states that had it before, or compared to the private schools in those states that weren't subject to the laws, or compared to the middle and high income kids in those states. So is it a smoking gun? No, but it's a natural experiment suggesting an unintended effect. District administrators are going to want to get kids diagnosed so that those kids could get treated, and next spring the test scores would go up. Or more perniciously and nefariously, before the Obama administration outlawed this in 2012, if you got more kids diagnosed in your district, well, they were now special ed kids, and guess what? Next spring, those scores were subtracted out of the district's average for reading and math. So it was a very intentional way of falsely boosting test scores through an ADHD diagnosis in order not to lose your district's funding. So what's the point here? Genes, as Anita explained so well in her brief time, genetic variation is by far the largest driver of variation in ADHD symptoms. Nonetheless, moving up levels of analysis, school policies may have a fairly huge impact on rates of ADHD diagnosis, especially for the most vulnerable, lowest SES kids in a given region in the US. And then finally, because I think I'm a minute or two over, none of this would happen if in the US, the professional guidelines from the American Association of Pediatricians and American Academy of Child and Adolescent Psychiatry were followed. Hundreds of pages of what you do to get norm-based parent and teacher ratings and do a developmental history interview and look for maltreatment and trauma and talk to the teachers directly and test for learning problems as you need to. The average kid in the US gets diagnosed in a single 12 or 15-minute visit with a general pediatrician with no specialty training. The average adult gets diagnosed in a general practitioner's office with absolutely none of the evidence-based stuff that I'm talking about here that would be needed for a careful diagnosis. So in the US, we can pretty confidently say that boys are overdiagnosed. Girls, however, because of their later presentation and the coping and compensation, and give a whole nother talk about girls with ADHD, are still at some risk in many regions of getting underdiagnosed. So thanks for the time. Sorry I couldn't get my slides in presentation mode. I will stop sharing my slides, but not stop sharing answers to questions, both now and in the general discussion.
Steve, thank you. Look, I think we haven't got too much time now for the next speaker, but we do want to ask you some questions. So are you saying, I mean, you spoke about direct-to-consumer advertising and you spoke about what's happening in schools. You're saying they're both factors that are driving overdiagnosis?
So we're finally recognizing that ADHD is real and exists.
Yeah.
The huge rates in California of autism spectrum diagnoses, the large majority of this is finally recognition and not calling kids with ADHD something else, which they've been called for decade after decade. But in achievement-driven society, so the two countries with the highest rates of ADHD diagnosis we know of are the United States and Israel. And we could do cultural analysis of the extreme pressure for treatment, and then everyone must go to college or university, unlike so many other countries where it's reserved for a much smaller number, and the pressures it puts on families and school admissions, et cetera. I think what we need to do, and one of the messages from the whole morning for me here and evening for you all over there, is shifting from multiple levels of analysis. Genetic influences, low birth weight, other biological factors are crucial for understanding who does and does not have ADHD. But levels of cultural messages and school policies may, at a top down, much higher up on the levels of analysis, also be a direct influence on who gets diagnosed when and where.
Okay, Alison, I know there are a lot of questions coming in and lots of comments. Just to remind everybody who's watching and listening, put your questions into the Q&A. Don't put them in the chat because they might get missed. But Alison, any general themes that you're picking up? And another question for Steve.
Well, there are lots and lots of questions coming in. But I think a really important one is this issue of being more child-centered in education, and is this calling for a change in policy? And now there are other countries that are doing it better, such as Finland, for example, which has very high attainment rates, but also less pressure in schools. So that's a question. Mm-hmm.
So when you get to this level of analysis, and I was trained as a clinical and developmental psychologist, not a policy person or an epidemiologist, there's a whole lot of uncontrolled factors whenever you try to look at regional, local, or national, or even international rates. There are many influences. In the UK, the hyperkinetic syndrome, et cetera, was very rarely diagnosed until much recently because it had different diagnostic standards and medications were hardly ever used. The United States, with its kind of Wild West direct-to-consumer ads, it was almost waiting for advertisements and supposed competition to drive up rates of diagnosis to help boost test scores. So I'm not saying that we have answers, but we've got some provocative natural experiments to show we need to look at various levels of influence to understand not only the individual, but the cultural phenomenon of ADHD.
Thank you. Alison, any one comment before we move on?
No, I think that's fine, Cameron. We should move on.
Okay, thank you. Steve, thank you. We'll see you again in the panel discussion, but thanks for that. Okay, our next speaker is Daniel Gorman. Now, we've spoken about diagnosis. Diagnosis ends up with treatment, and drug treatment is one of the options. And stimulant drugs clearly are often talked about, and the widespread use of stimulants in the young population has caused concern, as we know, amongst doctors and parents. So to take us through the benefits and the harms of treatment, we've got Daniel, and also talk about withdrawal. We've got Daniel Gorman. Daniel is Director of Postgraduate Education in the Division of Child and Youth Mental Health and a staff psychiatrist at the Hospital for Sick Children in Toronto. So Daniel.
So thanks so much, Cameron, for that warm introduction. Let me first share my slides, and hopefully this will work. And let me now go into presentation mode.
Yeah.
Is that okay?
Yeah.
Okay. So it's a real pleasure to be here to talk about drug treatment of ADHD. The question mark at the end of the title is deliberate, because I think there are a lot of questions about drug treatment of ADHD, including whether it should even be initiated for a given child. So in terms of disclosures, I don't have any financial disclosures, but one more general disclosure. Although I have done some research in my academic career, mainly involving knowledge synthesis, my academic career, as Kamran alluded to in the introduction, has been primarily as a clinician and as an educator. I'm actually no longer the program director for child psychiatry at the University of Toronto. I did that for 8 years and then stepped down from that role in the fall. But in that role, I was very involved in of course, educating, but more specifically, teaching around ADHD. So some of the information that I'm presenting here is really distilled from teaching really hundreds of residents over the last couple of decades on this topic. So with that perspective in mind, there are three known unknowns that I want to address in this talk. So the first one, it's a very straightforward question: who should take ADHD medication? But I think this is a real unknown, and we can't agree across the world, and we can't agree over time what the threshold should be for prescribing ADHD medication. A second big unknown is whether ADHD medication is effective in the long term. I think it's quite clear that ADHD medication, especially stimulants, improves inattention, hyperactivity, impulsivity in the short term. It's actually one of the gratifying aspects of doing this work, is that you see kids improve very rapidly before your eyes. But the question of what are the long-term benefits, I think, remains an important unknown. And then just as important, what are the long-term harms of ADHD medication? And there, unfortunately, we have very little robust research to inform us, although there is some, and I'm going to focus on the research that's been done on the effects of growth, including height. So who should take ADHD medication? As I mentioned a moment ago, we can't agree. We can't agree from one country to another, and we can't agree over time. So here it's a pretty busy graph, but what you have on the y-axis is the prevalence of ADHD prescriptions. And then on the x-axis, you have the year starting with 2000 and going through 2015. And you can see that the prevalence of ADHD prescriptions varies widely across the globe. It is highest in the United States. I always thought that the second highest was Iceland, but Steve mentioned that it was Israel, and I took a quick look at this graph and noticed that for some reason Israel isn't on it. So perhaps Israel is higher than Iceland, but in any case, those are sort of the outliers. Everyone else, including Canada, where I am, and the UK, are much lower, although no matter the country, there is an almost invariable pattern of increasing rates of ADHD prescriptions over time over the last 2 decades. Now, this red solid line is the estimated prevalence of ADHD. I think the figure that Anita quoted before is sort of a standard figure of 5%. Data that she actually also cited from Polanczyk and colleagues suggests that it might be as high as close to 7%. And so you can see US prescription rates actually approach that prevalence of the diagnosis itself. And so, if you think, and this is a big if, that every kid with ADHD should be treated with medication, you might argue that the United States actually has it right and everyone else is being undertreated. Of course, even in the United States, there would be the question, are these the right kids who are being treated with medication? Because there still could be kids who have ADHD who are not being picked up and not treated, and there could be kids who don't have ADHD but are being treated nonetheless. So even there are questions. But all this to say that there's a lot of uncertainty about who should be treated with ADHD. Now, one question that I want to highlight is why the increasing rates of ADHD prescriptions over time. I think there are many reasons for it, and some of them were discussed by Steve in terms of the influence of the pharma industry and direct-to-consumer advertising. But I think another important factor is this study, the multimodal treatment study of children with ADHD, which I think is pretty clearly the most important ADHD treatment study that has ever been done, arguably the most important treatment study in child psychiatry. It's had a huge influence. I think there's a lot to be admired in this study. And I think it's important more for the questions that it raises than the answers that it provides. It has resulted in literally dozens, if not hundreds, of publications. But this finding in the original paper is the one that I think really took hold and has influenced the increasing rates of ADHD prescriptions. So although it's a complicated study, I'm just going to go through this slide fairly briefly. So basically, the main goal of this study was to compare 2 different treatments and their combination for ADHD. So one treatment was medication alone, mainly involving stimulants. The second treatment was behavioral treatment alone, very intensively delivered. The third arm was combined treatment. So the combination of the very intensive, closely monitored medication treatment and the very intensive behavioral treatment. And then the control arm was community care. So these were children who were allowed to get whatever treatment they normally would get through the community, and they were assessed along with the 3 active treatment arms. And this slide is for hyperactive impulsive symptoms, but the pattern is the same for inattentive symptoms as well as for many other outcomes, as we'll see a little bit later. So everyone starts in the same place with a relatively high level of hyperactivity and impulsivity. And then you can see that there's this clear split where the 2 treatment arms that included medication through the study, so medication arm and combined treatment arm, they improved to a greater extent over 14 months, whereas the other 2 arms, and notably the behavioral treatment arm, did improve, but not nearly to the same extent. Although interestingly, the community care arm, 2/3 of those kids actually received medication in the community, and yet they didn't do nearly as well as the kids who got medication intensively and closely monitored through the study. In fact, they didn't do any better than the kids who got no medication alone, but got intensive behavioral treatment. But the sort of headline from this study is that medication is best, and more than that, intensive behavioral treatment doesn't actually add very much to medication alone, at least for the core ADHD symptoms of inattention, hyperactivity, impulsivity. What is not captured in this slide, and often relegated to the back pages, so to speak, is that for the associated problems that often go along with ADHD, so anxiety, academic difficulties, oppositional behavior, social problems, parent-child relationships, for all of those associated outcomes, which often are the real driver for why families present clinically, combined treatment was actually best. But as Steve said, the drug companies had no interest in highlighting that because they're not in the business of selling behavioral treatment, they're in the business of selling drugs. So I think that this really drove the increase in prescriptions for ADHD medications over the last couple of decades. And then about a decade ago, Alan Schwartz, who has written extensively on this topic for the New York Times, published an article that sort of took stock of the MTA. And I pulled out a couple of quotes from this article, which I think are particularly salient. The widely publicized result was not only that medication like Ritalin or Adderall trounced behavioral therapy, but also that combining the 2 did little beyond what medication could do alone. The finding has become a pillar of pharmaceutical companies' campaigns to market ADHD drugs and is used by insurance companies and school systems to argue against therapies that are usually more expensive than pills. But in retrospect, even some authors of the study, widely considered the most influential study ever on ADHD, worried that the results oversold the benefits of drugs, discouraged important home and school-focused therapy, and ultimately distorting the debate over the most effective and cost-effective treatments. So I come back to the question of who should take ADHD medication, and one somewhat simplistic but hopefully still useful way is to look at guidelines, both in the UK and in the US. So NICE guidelines that were published in 2018 and then revised a year later said that medication should be offered to children who are at least 5 years old, only if their ADHD symptoms are still causing a persistent, significant impairment in at least one domain, and then importantly, after environmental modifications have been implemented and reviewed. So they're saying that every kid should get behavioral intervention first, and the kids who still have significant impairment, those kids should get ADHD medication. In the US, though, at least according to the American Academy of Pediatrics, the threshold is lower. So there they say that for children 6 to 11, ADHD medication should be prescribed regardless, along with behavioral treatments. For adolescents, the threshold is even lower for ADHD medication because the emphasis is on prescribing ADHD medication while training and behavioral interventions are encouraged, but not more strongly recommended than that. All right, so let me come to the second area of uncertainty, which is ADHD medication effective in the long term? So I was sort of tickled when I learned that Steve was going to be on this panel, because for years I have shown this quote to my students, which is that the key paradox is that while ADHD clearly responds to medication and behavioral treatment in the short term, evidence for long-term effectiveness remains elusive. And Steve said this in a paper close to a decade ago, and I think that it remains true to this day. Now, to follow up on this, I know this is a little bit of a busy slide, but I'll try to take you through it. These are long-term outcomes from the MTA study. Now, the graph that I showed you before was the acute randomized portion of the study. So for 14 months, the kids remained in those randomized groups. After 14 months, it became a naturalistic study, and people did what they wanted. Some kids who had been taking medication through the study stopped it. Kids who weren't taking medication because they were in the behavioral arm, they started medication. And by 8 years out, there weren't significant differences in the rate of medication use based on the original random assignment. And what you can see is a pattern for multiple outcomes. So not just hyperactive impulsive symptoms, which I showed you earlier, but also inattention, oppositional defiant symptoms, aggression, just overall impairment, which is that after the active treatments stopped in terms of the randomization through the study and everyone could do what they wanted, the differences between the original groups attenuated by 24 months and completely collapsed by 36 months. So that by 3 years out and continuing through to 8 years and later data showing continuing through 16 years, there was really no difference based on original group assignment. This graph is the one that's not like the others because this is math, and this shows that even in the acute period, taking medication through the study did not help math. That treating ADHD is not enough to improve your math scores. Presumably, you also need tutoring or special remediation in math if that's an area where the child is struggling. So there was a recent, or at least a relatively recent 4 years ago, debate on this question of whether stimulant medications for ADHD are effective in the long term. And there were two authors who commented on both sides. So against this notion was Jim Swanson, and he argued that long-term effectiveness may not be significant based on different kinds of data. So randomized controlled trial, observational and register studies, patterns of medication use in clinical practice, and basically what he's pointing to here is that most teens eventually go off their medication. The reasons that they give for stopping their medication, which is often that they feel that the medications aren't working or cause intolerable side effects. And a fourth reason was the possibility of long-term tolerance. Now, arguing for this proposition that there is long-term efficacy was David Coghill. But I have to say, this is the most lukewarm for argument that I think I've ever seen in a debate piece. So this is how he formulates his argument. Does this, meaning the MTA long-term findings, mean that ADHD medications are not effective in long-term care? It might. And those who do not support the use of medication to treat ADHD are quick to jump to this conclusion. I suspect, however, that these data are telling us not that the medications do not work, but that we are not using them effectively. So hardly a ringing endorsement. It's mostly his suspicion that if kids were treated long-term in the same intensive way with medication that they received during the first 14 months of the study, that we would see the longer-term outcomes. But of course, that's an open question. And in fact, I think there are two key questions here. One is, if patients were to receive MTA-style medication titration and monitoring in the long term, would they in fact experience long-term benefit? Or would all the other factors, social factors, natural development, life experience, and so forth, would those still overpower the effects of intensive medication treatment? The second question is that even if this were true, that intensive medication treatment in the long term would confer long-term benefit, the question remains, is it feasible to provide long-term MTA-style medication titration and monitoring in the real world? So finally, what are the long-term harms of ADHD medication? Lots of questions here, the effects on growth, the effects on brain development, effects on cardiovascular health. Stimulants are known to increase heart rate and blood pressure, usually by small amounts in the short term. And also in the case of heart rate, those elevations persist. But what does that mean clinically in terms of cardiovascular health? do they increase the risk of developing a psychotic disorder, of developing bipolar disorder? There's a controversy about the risk of suicidality with stimulants. And what about tolerance? I've had quite a number of patients over the years where their parents tell me that when the child is off medicine, their ADHD seems to be worse than at baseline before they even started the medicine. Is that recall bias, or is there a tolerance effect that is happening? So each of these questions could be a talk in itself, but I'm going to leave you with just some of the data on the effects of stimulant treatment on growth. And again, these come from the MTA. So in the long-term studies, when the individuals were now young adults in their mid-20s, they compared, not by original randomized group assignment, they compared the individuals who had consistently taken medication throughout their childhood and adolescence to the group who hardly took medication at all for that decade and more. And what they found is that in the first 3 years, there was a 2-centimeter decrement in height in the individuals who had taken medication consistently. Now, at that point, there was the hope that those kids might catch up later on. But in fact, the more recent data looking at final height found that they didn't actually catch up. In fact, they had even more vertical growth suppression, totaling about 4 centimeters. Now, again, this is actually in a minority of individuals who consistently took medication for over a decade. It was only about 7% of the entire sample. And I think very intriguing is that despite the common phenomenon of appetite suppression and weight loss in childhood, as adults, these individuals who had taken medication consistently throughout their childhood and adolescence were actually 4.5 kilograms heavier than individuals who had not taken medication during that time. So I'm going to end there. I'm sorry, I think I have gone a little bit over, but hopefully that was useful, and happy to take any questions.
Daniel, thank you very much. Really interesting data you presented. So we'll come to Alice in a moment. To summarize what you're saying the trial that you discussed there, it demonstrated benefit under trial conditions at 14 months over that period, but over a longer period of follow-up, when trial conditions were no longer applied, that effect disappeared essentially. And then when you look at the adverse effects of taking stimulants long-term, there are particular ones there that you highlighted. Is that in a nutshell the summary of what you said?
Yeah, I think that summarizes it very well, maybe with one small clarification.
Yeah.
I think the negative impacts on growth have been most clearly studied and articulated. I think the other potential long-term impacts are more question marks. So I think those are known unknowns, in my opinion.
Yeah. In that study that you just mentioned, where was it 7% of children did continue to take drug treatment? What about their symptoms in relation to ADHD? What was the long-term picture?
Yeah, so that's also fascinating. Now, you have to appreciate, of course, that these are self-selected groups, so it stops being a randomized trial. But there was actually no difference in ADHD symptoms, no matter which comparison you looked at. So one comparison that they looked at was individuals who had taken medicine either consistently or inconsistently for that decade and a half, and compared them to those who had negligibly used medication. No difference in their ADHD symptoms. They also compared the group that had consistently taken medication versus the group that had taken medication but inconsistently, so less than half the time. And again, no difference. Now, one important clarification is that when they were rating the symptoms, if an individual happened to be on medication, their symptoms were rated on medication. So, you could argue that the people who were still taking medication, especially consistently, maybe their symptoms were worse, and therefore they were still benefiting from the medication, since their symptom level on medication was no different than the individuals who were not taking medication or were taking it less consistently. But the simple answer is they weren't able to find any differences in ADHD symptoms no matter what comparison they looked at. I think it's also interesting that only 7% continued to use medication consistently. And I think that there are interesting questions about why that's the case in terms of the benefits experienced by those individuals, the side effects, but also health systems issues. As a child and adolescent psychiatrist, I have a real challenge transferring care to adult psychiatrists who feel comfortable managing and monitoring ADHD and ADHD medication. And so I think a number of patients, they just sort of get lost to follow up because of the way our mental health systems, at least in North America, are structured.
Okay, thank you. I'm going to turn to Alison quickly before we go to Edmund. Hello, I know you've appeared on screen. Alison, again, lots of questions coming in. Can you pick out one at this moment for Daniel?
There's some interesting ones asking about the use of drug treatment for ADHD and subsequent use of illegal drugs or addiction or substance misuse disorders. So I don't know whether you have any data on that at all, whether it reduces, increases likelihood.
Yeah, so that almost feels like a planted question, because although I focused on growth, the question around substance use outcomes is one that people have long thought about, but now we actually have new pretty good data. So I think that this is, dare I say, no longer a known unknown. I think we actually have good data about it. And the short answer is that data both from the MTA that was just published earlier this year, as well as data from meta-analysis, has found that stimulant treatment in childhood neither increases nor decreases the risk of later substance use. Now, you can find studies that will show a reduced risk of later substance use. And early on, I think people latched onto that finding, and there was a kind of lore that one of the rationales for treating children with stimulant medication is to prevent later substance use. But I think now the preponderance of the evidence is pretty clear that it doesn't decrease the risk of later substance use, but also reassuringly, it doesn't increase that risk either. And I think a lot of parents are concerned about their child, becoming drug addicts if they're treated with stimulant medication. I think that we can fairly confidently reassure families that ADHD medication doesn't increase the risk, even if it doesn't reduce it either.
Good.
Thank you.
Daniel, thank you. Alison, any final comment before
I've got a couple of other questions that are coming in around food and nutrition and processed foods and metabolic syndrome, and whether there's any association with ADHD, and whether there are any studies looking at changes in diet on that, or and the association between metabolic syndrome. That's one. Do you want to answer that one, Daniel?
Yeah, let's take that one, then we'll move on. So any interventions, any dietary interventions that are beneficial, Daniel?
I could answer it, but I wonder if Edmund might be better placed to answer it, because I think that's sort of in his wheelhouse and probably part of his talk, and I don't want to do more than I think he will do on that topic.
You are drug treated. We'll give you that. So Edmund, why don't you store that and come back to that?
I'll store that, because I'm not actually going to talk about it, but I can talk about it after my presentation. Done quite a lot of work.
There is another one on non-stimulant medication and the potential role of that. Could you expand on that, non-stimulant medication and also the placebo effect? So there are a few on that one as well coming in.
Sure. So I'll take the last one first. The placebo effect for stimulants for ADHD is actually relatively low. So by comparison, if you look at the response rate of SSRIs for adolescent depression, it's respectable at 60%, or at least it seems respectable until you realize that the placebo response rate for adolescent depression is 50%. So that's a difference of only 10%, and it results in a number needed to treat of 10. For stimulants, though, for the first stimulant that you try, the response rate is roughly 70%, and that's what was found in the MTA, whereas the placebo response rate is quite a bit lower. I've seen estimates ranging from 4% to 30%. So there's always some placebo response, but I don't think it's as big a factor when it comes to ADHD medication as opposed to antidepressants for depression, certainly. In terms of stimulants versus non-stimulants, stimulants are usually first line for a few reasons. Basically, they work better. Their effect size is greater and the response rate is greater. Also, they work right away, and they can be used flexibly. So you can start them and stop them easily. You can use them during the week and not use them on weekends. And I think families often appreciate that control and flexibility. On average, non-stimulants, and I'm referring specifically to atomoxetine, trade name Strattera, or the alpha agonists, so clonidine and guanfacine. And although it's not approved or as well studied, there's also bupropion. They have smaller effect sizes. In the case of atomoxetine and alpha agonists, about 0.6, and they typically take weeks to months to bring about their effects. But they have their place in the toolbox. Not every patient will respond to or tolerate stimulants. Also, non-stimulants provide continuous coverage throughout the day. And so for children who have a lot of difficulty early and late in the day, when they don't have stimulant coverage, a non-stimulant can be useful. And also they have a different side effect profile, non-stimulants do. And so for children who are having a lot of trouble with appetite suppression, weight loss, that can't be managed, although often we can manage it, but if it can't be managed, a non-stimulant might be a reasonable consideration.
Great, thank you. I'm going to have to move us on. Alison, thank you for those questions and those that input. Daniel, thanks a lot. We'll come back to you in the Q&A, the group Q&A at the end. But now we're going to go to Edmund Sonuga-Barke, and Edmund is going to talk about psychological therapies. And you know what they might mean for people with ADHD. So Edmund is Professor of Developmental Psychology, Psychiatry and Neuroscience at King's College London. Edmund.
Thanks, Cameron. Good evening, everybody. So the search for an effective non-pharmacological alternative for the treatment of ADHD is so far, it appears to me, a story of noble ambition which has been dashed on the rocks of rigorous empirical research. So we've learned a lot from this research. Daniel's talked a bit about the MTA study, for instance, over the last 30 or 40 years. But we are little the wiser, really, about what we should recommend, at least in terms of psychological interventions. So what do we know? And what are our known knowns? Well, first of all, we know that medication, as Daniel has said, is not the complete answer for patients with ADHD. And as he said, the magnificent MTA study highlighted the way in which ADHD impairment persists, irrespective of prior exposure to medication. Secondly, we know that psychological interventions are recommended by guidelines groups such as NICE as part of multimodal treatment strategies alongside medication. Thirdly, we know that a wide range of psychological interventions have been tried in the treatment of ADHD. Some have focused on supporting parenting. Others have targeted the brain more directly, such as cognitive training or neurofeedback. Others have taken a more psychotherapeutic approach or focused on development of particular skills which are impacted by ADHD related dysfunction. Fourth, and most disappointingly from my point of view as a psychologist, is that rigorous meta-analyses of randomized controlled trials limited to well-blinded outcomes with low risk of bias do not support these interventions in terms of ADHD symptom control. However, some of these interventions, of course, have other benefits, particularly in the areas that they're targeting in terms of, say, specific functions, say, social skills, improve ADHD kids' social skills, for instance. Others have no apparent other benefits. Hard to find the benefits of neurofeedback, for instance. And now this is all becoming clear at a time when there's increasing calls for reconceptualization of ADHD and attempts to rethink the purpose of psychological interventions, but also interventions more generally for ADHD. Now, all this together leads me to conclude really that there's an urgent need to reconsider the purpose of psychological interventions. And in this short talk, I'd like to focus on three aspects of that reconsideration. I'd like, first of all, to focus or discuss the reframing of the purpose of psychological and indeed pharmacological interventions in the treatment of ADHD, brought about by this call for reconceptualizing ADHD from the neurodiversity movement. And secondly, I'd like to discuss the refocusing of our intervention strategies that are implied by such a reframing. Finally, I'd like to focus on the whole issue of heterogeneity of ADHD and the need to target intervention strategies to the specific circumstances of patients, an area we haven't discussed yet, I don't think. So in terms of the first part, in terms of the reframing of the purpose of interventions for ADHD, in particular, in this case, psychological interventions, we can phrase this reframing in terms of the recent calls for a paradigm shift brought about by the neurodiversity perspective from understanding people with ADHD as neurodisordered and in need of treatment to understanding them as neurodivergent, where their variations in action and thought have value in themselves and that they are supported to thrive as individuals. And we can think about this paradigm shift diagrammatically in this way. So in the disorder paradigm, supported by the medical model and instantiated in the DSM-5 now, diagnostic manual, we assume that ADHD is the result of brain dysfunction that is expressed as disorder, which by its very nature leads to impairment in terms of its negative impacts on everyday life. Of course, the purpose of intervention here is to fix the dysfunction, reduce the disorder, and particularly could say the symptoms, the focus being on symptom control, which in turn, by its very nature, should resolve the impairment and improve the functioning. Now, of course, the neurodiversity paradigm turns this all inside out, so that we talk of brain atypicality rather than brain dysfunction. We talk of differences in thought and action rather than disorder that then relate to or bring about certain experiences that may or may not lead to positive versus negative outcomes as a function of the context or the environment in which these people with ADHD find themselves or are placed. So, of course, here the intervention purpose from this paradigm, this alternative paradigm, is very different. No longer the focus on brain dysfunction and the control of symptoms, but rather the promotion of positive outcomes via affirmative experiences. So the shift from the focus on the neurobiological basis of the condition to the focus on the experiences had by people with ADHD, modifying those experiences. And we can think of those outcomes, those positive outcomes, in developmental terms rather than in clinical terms. And we can think of them, or I like to think of them, as an arc of growth, creating an arc of growth for the ADHD individual. So moving from acceptance, and Steve talked about removing stigma, for instance, going through to the individual feeling actually positively valued for whom they are, uncovering their hidden strengths and talents, leading to them to gain agency and control in their lives through the development and the promotion of resilience, then leading to thriving. Now, of course, if we think about outcomes in that way, that promotes or broadens our strategy for intervention quite substantially, and certainly reframes that strategy. So again, I know, again, Steve just talked about this and written a lot about public awareness campaigns that can increase acceptance. The movement to introduce reasonable adjustments into environments that can lead to individuals feeling valued or being valued, and their strengths being uncovered. The promotion of confidence through the development of skills that leads to the gaining of agency, the careful, graded or scaffolded presentation of challenges that can promote resilience. So this is just an example of the sort of intervention strategy that you might think of from a neurodiversity perspective on ADHD. Now, of course, other interventions, including medication, can also play a vital role in these developmental outcomes in supporting this arc of growth, if you like, for children. But they should be judged on how they promote that growth, how they support the gaining of agency, and how they help the development of resilience and the thriving, rather than just on the degree of symptom control or even on the amount of impairment that they alleviate. So the long-term focus, and we've talked about, and Daniel talked brilliantly about the long-term impacts of medication. And I think taking a developmental perspective really broadens the focus for our intervention strategies. The third point that I'd like to focus on is this whole issue of heterogeneity. And we know that ADHD is a massively heterogeneous condition. Of course, we've known about this for a long time in terms of symptoms and impairment, and that's been our focus. And of course, we've addressed that by the development of subtypes, inattentive, hyperactive, impulsive, trying to partition that heterogeneity. Now, we, of course, in DSM-5, we call them presentations, because we realize they're not really stable entities. But of course, individuals with ADHD don't just differ in terms of their symptoms and impairment. Crucially, from this focus on contextual factors, they differ in terms of the environments to which they're exposed. So we could take very broadly, say, from a socially depriving environment versus a non-socially depriving environment. They also differ enormously, we now understand from brain imaging studies and laboratory neuropsychological studies, in their underlying neuropsychological processes. So for instance, the kind of headline story would be that a large minority of individuals with ADHD show no evidence of executive dysfunction on laboratory tasks. Now, these factors have never really been properly considered in the planning or the implementation of psychological interventions, or to a large extent, pharmacological interventions either, but they do give rise to very different intervention needs. And so we need to tailor our strategies and personalize those strategies to meet the specific circumstances of individuals. And crucially, our trials to evaluate the value of these strategies, our randomized controlled trials, need to stratify by these heterogeneity factors, whether they're contextual factors that may or may not inhibit change, or underlying neuropsychological processes. So very quickly, in terms of the research agenda that this kind of radically different way of thinking about ADHD brings, I mean, first of all, we need to identify which experiences promote personal growth, promote that arc of growth, promote agency, promote resilience in people with ADHD. And we need to know why that's the case. What are the mediating factors underpinning or driving these positive experiences? What are the moderating factors? And we've talked about some possibilities in terms of heterogeneity in experience and psychological processes. We need to evaluate these interventions against their ability to promote growth and development, and not just to control symptoms and reduce impairment in the short term. We need to understand, in terms of heterogeneity, who benefits from which interventions. And in practical terms, we very much need to think about how to optimize the timing and the setting of interventions. So for instance, does early intervention give more traction with regard to psychological approaches. Would supporting families more generally and improving the family context increase agency and resilience? And finally, we need to study adverse events, but broadly considered, not just in terms of those adverse events that we know are linked to medication, but we need to think very much in terms of developmental outcomes. And Daniel gave a list of potential adverse long-term outcomes, but didn't talk about resilience, agency, and growth, psychological growth. So I do think we need to look at the impact of interventions on those and the unintended negative consequences on those sorts of outcomes as well. So thank you very much.
Edmund, thank you very much. It took us an hour and 15 minutes, but somebody mentioned neurodivergence. We got there. Could you stop sharing your slides, please?
Yeah, of course.
So let me ask you about that first of all. I mean, clearly that's a term that's increasingly being used. And you also use the term neurodiversity. Perhaps you might explain, are they the same? Are they different? Are they interchangeable? And also, aren't we all neurodivergent by definition?
No, we're not. So I would say, no, I mean, conceptually, the term neurodiversity is often misused in the sense that it really relates to a population and not to an individual. So to say you're neurodiverse doesn't really make sense. Unless your brain is changing from moment to moment, then you're neurodiverse. A population is neurodiverse, an individual, I would say, is neurodivergent.
Okay.
And what we mean by that is that they are divergent from the norm, I suppose, along any particular dimension. In this case, we're talking about ADHD. I mean, most are commonly used, of course, in relation to autism, is where the whole movement really came from, but is being applied much more to thinking about the rights of people with ADHD as well now, I think.
Okay, good. Thank you for that. Now, you talked about the heterogeneity, and then of course there's a range of interventions. So how are we going to push back the boundaries of what we know and don't know in that scenario? It's going to make constructing studies rather difficult.
But I think they are rather difficult. I think we've kind of glossed over how complex, because medication has this sort of generic, or say psychostimulant medication has this sort of generic effect across individuals, probably because it hits so many different brain networks. We've kind of glossed over the issue of precision medicine and tailoring, and we've kind of had a false sense of the challenge that we actually face in terms of getting the right treatments to individuals. So I think they are complex. And I think they should be translational. So we really, I think I mentioned, we really need to understand, at least from the point of view of psychological interventions, which environments and which experience lead to long-term positive outcomes. And I think that's a whole program of research in itself that we haven't addressed because we haven't had this perspective, really, I would say.
Okay. Thank you. I thought your reframing actually was really fascinating. But I'm going to call in Alison at this point. Alison, what questions are we getting from?
I'm going to do diet. I was going to comment.
Oh yeah, do diet, and then we'll call in Alison.
Yeah. So diet.
What do we know?
We know quite a lot about diet. I mean, in terms of treatment studies. I don't know if you remember, but in 2007, Jim Stevenson, a colleague of mine, and me and myself, me and another set of colleagues, we published a big trial in The Lancet where we showed that artificial food colorings and flavorings actually did have a small but very robust impact on ADHD symptoms. It was an exclusion trial, and that actually led to the change in the labeling of foods. So it was I think they're called the Southampton 7, actually, because that's where it was when we did the trial. But tartrazine, for instance, was one of them. Allura Yellow was another of them. But they did actually, compared with the placebo, increase the levels of hyperactivity.
Just to be clear, what you're saying is, if by excluding those,
we reduce the levels of hyperactivity. Exactly. So, I mean, it was a small, it was about 0.18 standard deviation. So, you know, at an individual clinical level, really rather than insignificant, but at a group level, it was really quite important. Now, in terms of the clinical trials, there's two areas. There's obviously supplementation, and that's tended to focus on omega-3 and omega-6. And again, there's good evidence, I think, from multiple meta-analyses, including some of our own in the European ADHD Guidelines Group, that there's a small but statistically significant and very homogeneous effect across studies of omega-3, omega-6 supplementation. Small. Okay. You're never going to, I mean, you aren't going to have a clinical effect at the individual level, but again, as a kind of a public health intervention, quite important. Now, in terms of exclusion studies, whether it's the Fine Gold diet, which excludes specific provoking food elements, or the removal of artificial colorings and flavorings, the effects depend almost entirely on whether the people entering the trial have known food sensitivities. Okay. So as a general treatment for ADHD, probably not, but in people where there's a suspected food sensitivity around particular things, certainly worth a look.
Okay, so again, it's your point about tailoring it to the individual very much. Yeah. Okay, thank you, Edmund. Alison, any particular questions?
I have, but I'm aware we're going to shortchange.
Let's take one. Let's take one.
Well, this is really one for everybody to hold, which is the pros and cons of neurodiversity. And many people have said, are there parallels with the disability movement? Have we got too much focus on the individual and not enough of society as a whole? So maybe people could hold these questions, pros and cons.
Okay, well, fine, let's do that.
But I think we should move on because we've got
a great question, Alison.
Yeah,
thank you. Good. Thank you, Alison. Edmund, thank you. That was really fascinating. We'll come back to you at the end. Right. So next we've got Kirsty. We've had experts talking about ADHD. Kirsty has lived experience of ADHD. She's a student about to start a PhD, and she's written one of our, we call them wipe it's what your patient is thinking articles, a very good one about having ADHD and how poorly the NHS makes adjustments for people with that diagnosis. So Kirsty, tell us a bit about yourself.
Yeah, thank you for having me. Yes, I'm Kirsty, I'm 24. I was diagnosed with ADHD 2 years ago now, so it was in the final year of my undergrad. And I also have been diagnosed with autism a few weeks ago, so that's a bit newer. But I've seen some of the questions about the sort of similarities between them. So I'm doing a master's at the moment on athlete mental health, but I'm going to be going on to a PhD. And then other than that, I just play a lot of sport. So my life, I don't really sit around because, yeah, sport's been a helpful way for me to manage my ADHD. So you'll either find me studying or playing sport, basically. Yeah,
so you find it helpful, a bit like, you know, we were talking earlier in terms of the baseball players we spoke about.
Yeah, I thought that was really interesting. I think when I was younger, I played a lot of sport too, like the structure of it helped and everything like that. As well as the activity levels with it. And then when COVID happened, obviously we couldn't do things like that, which is when my ADHD symptoms got a lot worse, because obviously I was still doing activity, but the structure around my day had been taken away.
Okay, and so did that prompt, what is that what prompted you to seek a diagnosis?
There were a few things. It's really obvious when you live with me. I'm going to make myself sound like a terrible housemate now. But in uni, in my second year of uni, a friend was like, have you ever been diagnosed with anything? I was like, no. She was like, have you heard of ADHD? And I was like, yeah, but I don't have it, because I think for me, the name disorder and like attention deficit hasn't been particularly helpful, because I've done quite well in school, education, things like that. And I've managed to just keep up. But then another friend, when I came back from Australia for a study abroad year, was like, should we just do a few questionnaires together online? And I passed with flying colours. So that kind of prompted me to think, oh, maybe I have it. I looked into it a bit online. not really on social media, to be honest, but like listen to some podcasts, and then I could actually self-refer. I called the GP, and then I could self-refer where I'm located. So that kind of prompted it, but it's mostly obvious when you live with me. When I lose things, I am chaotic, but it's better now that I'm on medication.
Wow. So it was your friends that prompted you to kind of look into it more. Do any of them have a diagnosis of ADHD? Is that what you're aware?
No, well, I think not the ones that asked me, but actually since being diagnosed, there's been a few people that I'm friends with I didn't realize, and I think maybe that's because we feel more comfortable together. But also I'm friends with lots of people who definitely do not have either ADHD or autism. So yeah, sure, there's a mix.
And for you, what was the process of getting diagnosed like? How did you find that?
I feel like I've been very lucky in the NHS. Mine's all been through the NHS. And I went to the GP, didn't have any problems there. Where I'm located is an 18 to 25 service for mental health services, and so I could self-refer for an ADHD diagnosis. But the wait for that was like a couple of months to get your first phone call. And because I did it in COVID, they did the questionnaires on the phone with an ADHD nurse, I believe, which was really interesting. I think I didn't really understand what ADHD was, but you learn a huge amount about yourself through doing the questionnaires, like the self-awareness. You're like, oh my goodness, is that ADHD? Is that me? Like, you don't know whether you've passed or failed or whatever. And then, so I did those over probably about a 7-month period. And my mum also did a childhood one, because some of the questions are focused on like comparing to when you're 7 years old, and memory is not necessarily on my side, so I could not remember other than what people had told me what I was like when I was 7. So that was really helpful. And then I just had an in-person appointment. I think my psychiatrist is actually here listening, so Dr. Sang, a shout out. But so, and then that was it. That by that point they'd kind of collected everything they needed to, and it was just going through everything. But yeah.
And you've had treatment. Are you able to talk about that?
Yeah, for sure.
Yeah.
It was interesting to hear the talks about the medication. So I've tried. I'm going to try and remember I remember them as the actual names, but so I tried methylphenidate, which is also named as Ritalin, to start with. I was very resistant to go on medication, I should say. So Dr. Sang will know I was a bit stubborn. It took me a while. I sent her an email with 15 bullet pointed questions, because I think it's a big decision to go on to something like that. I didn't get on with the stimulants. So I tried both of them, methylphenidate and lisdexamfetamine, and I'm now on a non-stimulant atomoxetine, because I struggle with side effects with the stimulants, similar to what I think Daniel was saying. And I prefer, I think, with the autism side of things, the continual having it in me the whole time, and I struggled with the stimulants on-off switch, which I could definitely feel. So I'm on atomoxetine, still playing around with the dose, because I've been a bit stubborn to go up, because I don't think I'm ADHD enough to warrant going on the dose I'm supposed to be on from a medical perspective, but we're still going with that. And I'm also on sertraline to manage my autism side of things, so I think that's quite common to go on a combination.
Okay, I mean, I think whatever works for you. I mean, your psychiatrist is here, you said, so, but
I think so.
Well, let's hope so. But tell us your conversations with your psychiatrist and your GP. How have you found those? Have they, how have those discussions gone in terms of what to do?
Largely I haven't had to be very involved with my GP, and I know that's quite uncommon just to the way I self-referred, and I know people do have issues or bad experiences with GPs, but my psychiatrist has been super helpful. We've discussed absolutely everything, often multiple times, because I can be a bit come back every time. I'm like, have you got a genetic test I can do yet to prove it? So but it's been super helpful to sort of go through the medications and the positives and the negatives, and weighing those up. But although it took me a long time, I think for me, being on medication has just really helped me to actually implement other strategies, what Edmund was talking about, maybe other not necessarily interventions, but for me in my life, I didn't have the ability to implement those things without necessarily being on a medication.
Okay, gosh, I mean, lots happened. But how are you living day to day now with ADHD?
Yeah, it's an interesting one. There are ups and downs, I suppose, with anything. I'm definitely more like level now that I'm on medication, but I do have days where I'm, well, even within a day, like super up, and hyperactive and talking really quickly. I'm aware I'm probably talking very quickly right now. But then also days where I'm completely wiped out. So now I have an ability to nap because I can quiet my brain down. But yeah, day to day is fine. I think a big thing for me was accepting the help, because I thought I'd done okay in education and everything like that. I didn't feel like I should accept help, but now I have like a mentor at university who's really helpful, supervisors who are aware. I live with a housemate that's really helpful, tries to help me remember things as I leave the door, and just, yeah, slowly learning. It takes a while, and I would say that I've only now, after 2 years, like accepted it, and yeah, so getting there.
Well done.
Thank you.
Yeah, but let's go back to this piece you wrote, which I thought was really excellent for us. And you talked about the NHS and how it wasn't, fit for people with your diagnosis, and could do more. What were the key points of that?
Yeah, I haven't actually written the piece yet because
Okay.
it's coming. That's how I got invited to this. But it was about my experience of having some surgery in the NHS, and how I actually really struggled with sort of like my black and white thinking, not necessarily understanding what the clinician was saying, and actually was surprised that they hadn't heard of my medication. They were eventually very accommodating. I had my own room and things like that. I think one of the major things for me was the consultant saying, "Oh, you'll be back on the hockey pitch after 2 weeks." So I was literally like trying so hard to like increase my activity levels after having this, well, it wasn't major surgery, yeah, sort of major surgery. And I think that's where sometimes the communication style kind of got lost, and where that would really have benefited me having stuff maybe written down as opposed to on a phone call, like remember to bring this and this and this. Yeah, I think that was it.
Okay, well, that's great. Listen, obviously, yeah, we look forward to seeing the final piece.
Thank you.
I know what you're going to be talking about. So I think that's really excellent. Listen, thank you so much for sharing your experience with us. I think it's really valuable, and some of the comments I'm seeing on the chat, I think people have found it very moving, very inspirational. I think we're very grateful to you for sharing, your experience with ADHD. But you'll stay with us, won't you, for the
Yes, thank you for having me as well.
No, you're welcome. Thanks, Kirsty. Right, let's move on to our next speaker, who is Elia Abi-Jaoude. And we started off by thinking about known unknowns, and one of the speakers did mention TikTok, and I know you've been mentioning it in the chat, a lot of you. So this phenomenon of ADHD talk, and how that's feeding self-diagnosis and then clinical referral. So to talk about that and associated impacts, over to Elia, who's a assistant professor and clinical investigator in the School of Psychiatry at the University of Toronto. Elia.
All right. Thank you, Kamran, and thank you, everyone, the fellow panelists, but also all those of you who are attending. There's not a lot of time left, so I'm going to be quick. I'm going to talk probably almost as fast as Kirsty. It's been brilliant talks that everyone has seen, and I think it's a good way to end with this last talk. Although hopefully we'll have time for discussion. Dr. Thapar started us with history, and then I'm ending with some of the current. So this is a fairly recent phenomenon that's been going on in terms of the impact of social media. There's a lot of unknowns there, and hopefully we'll be able to chat some about them. To tell you just a couple of quick things about me. So my main area of focus and expertise is in Tourette syndrome. And so as a result of that, I see a lot of patients with not just Tourette syndrome, but also ADHD. And I often do make this diagnosis. I do prescribe medication and other interventions for ADHD. At the same time, I also work in a different setting on an inpatient unit where I see adolescents that are struggling with various mental health issues, typically affective difficulties. And I've been, as a result of that, I've been able to witness some of the increase in the numbers of adolescents that are having such struggles. And I've been very curious about the impact of social factors in this, and in particular, social media. All right, I don't have any financial conflicts of interest to disclose. I'm going to start by showing people this. This is a graph. This is from the CDC in the United States, the National Syndromic Surveillance Program, that looks at weekly emergency department visits for various things. And this graph is in particular is for tic disorder, for my area of focus. So, and in the solid line is females and the dotted line is males. And then around this time point here, so early in the pandemic, we see this massive rise in the numbers of females presenting to the emergency department, not just having tics, but so problematic that they're presenting to the emergency department in females in particular. And I was seeing, as a tic specialist, I was seeing this, and I was very curious. I was very perplexed about it. I was actually doubting myself. I was starting to question my own clinical diagnosis approach as I was seeing these patients. And at the time, I didn't know that this was something that was being seen elsewhere. It was in my own little world here in Toronto. Until I saw this article, Tics, TikTok, and COVID-19, and they talk about a group in London, England, who were having similar experiences. And since then, there's been dozens and dozens of papers published specifically on the massive rise in number of patients presenting with tics. And I should put in quotes, tics, often in the emergency department, often very severe and impairing, and often receiving a diagnosis of a tic disorder, particular Tourette syndrome, severe Tourette syndrome. However, with a trained eye, by an experienced specialist, they will say these are different than typical tics. These are what we call functional tic-like behaviors. So this is not a new phenomenon in the sense that there's often happened around the world in different places. There'd be pockets of contagion of young people experiencing things because they're seeing other young people having similar kinds of behaviors. However, in the context of social media that is global, this did become a global phenomenon, and this is something that's happened, was seen around the world. Well, it's not just tics, it's many other things. And if we look at social media, and if we look at TikTok in particular, there are many things that are trending on TikTok. And I don't mean to be dismissive of these labels as being not real or anything like that. But I do want to say that there's a massive popularity for all of these things on TikTok. And in many cases, I'm sure there are positive effects from it. It might lead someone who was struggling with certain things to maybe better understand, maybe reach a diagnosis that was not previously recognized. However, it also may lead a lot of people to start interpreting their experiences in clinical terms, and maybe having labels that might not be the most helpful for them. And the other thing is, regardless of whether the label is accurate or not, these kinds of experiences often can be quite impairing. And the level of evidence in terms of how contagious these things can be is variable, but in suicidality in particular, we have centuries of evidence that suicidality is quite contagious. And when there's a lot of discussion on that, whether it's on the news or social media, it can lead to increased similar experiences. All right, so our focus today is ADHD. And in particular, the most popular social media platform among young people is TikTok. And this has gotten a lot of attention, no pun intended. And this was an article in the UK that got a lot of attention. TikTok accidentally detected my ADHD for 23 years. Everyone missed the warning signs. I do not know this young journalist who works for The Guardian, and I do not know the extent of the accuracy of her diagnosis, but I just thought the article was quite interesting. There are some quotes from the article that I thought were interesting. For 23 years, my parents, my teachers, my doctor, my psychologist, and my own brain all missed the warning signs. It only took the app's algorithm a few days to accidentally diagnose me. So I booked a doctor's appointment and 3 referrals, 4 months, and about $700 later, my new psychiatrist looked straight into the webcam and said, "Yes, I think you clearly have ADHD. You've had it your whole life." Well, ADHD gets a lot of views on TikTok. We did what do these videos with ADHD look like? We did a study published just last year on this, where we looked at the 100 most popular videos on ADHD on TikTok and evaluated them. And they had a total at the time of over 280 million views, which I can tell you now would be several folds more. And just over half were classified as misleading, inaccurate and misleading. 27 were personal experiences, and 21, so about a fifth, were actually we found to be useful. I want to say the hashtag ADHD at the time had 4.3 billion views. A year later, this was over 10 billion views. Now it's well over 20 billion views. This is massive, the amount of attention, sorry, again, no pun intended, this gets on social media. But it's not just exposure to the videos themselves. Viewers who see these videos repeatedly get targeted ads, specifically by private online clinics that can diagnose ADHD or assess at least for ADHD for a fee. And what do these clinics look like? How does it work? There's a lot that one can talk about this, but there's an interesting panorama program from the BBC that was made specifically about this, where a journalist went to the NHS and got a thorough assessment, the kind that Dr. Thapar would make, and cost him nothing. And he was told he did not have ADHD. And he then went and attended 3 different of these online private clinics and shared the same symptoms, and gave the same answers that he gave to during the assessment at NHS. There were various fees. They were shorter than the typical NHS thorough assessment for ADHD. And all 3 of these, he got a diagnosis of ADHD, and treatment was offered with the drug. And it's not just, there's a lot that has already been said about the pharmaceutical industry, so I will not belabor this, but this is a recent ad that is quite interesting, in particular for adult ADHD, and that looks like depression, sounds like anxiety, might be ADHD. It just shows that when we're struggling to understand some of our experiences and why we're struggling, it's very easy to start to consider different labels, and it's easy to wonder if that explains our experiences. What are the current factors that could be going on that could be contributing to ADHD diagnosis? Well, first of all, ADHD itself is one that's tricky. As Dr. Thapar told us early on, it exists on a continuum, and it's pretty arbitrarily where we might draw the line to decide that this is normal versus pathological. We live in a world where we're constantly bombarded with all sorts of stimulation. We could talk at length just about that. But this boring baseball game that Dr. Hinshaw talked about, well, we don't even need to deal with the boredom anymore. It doesn't matter where we are, because we have our little gizmos, and we can get our hits of rewards, of stimuli anytime we want. These same gadgets are highly distracting in anything that we're trying to do, whether it's schoolwork or work. The other thing is the doing schoolwork in the online and the virtual context does make it harder to focus and complete our tasks. There's overwhelming evidence about how these gadgets, these portable digital media devices, are impacting our sleep in a negative way. Our society is chronically sleep deprived, and we know that this does impact our ability to focus and pay attention. As a result of all of this and other factors as well, we might be experiencing a lot of stress. There's increased expectations. We're a much more competitive society today, even compared to 20 years ago. Dr. Hinshaw used the term an achievement-focused society. So we're constantly struggling and feeling inadequate in terms of not being able to complete as many tasks as the person next to us. And we might start wondering, is there a reason? There's a clinical reason that can explain this. I've talked about this, and then it becomes very easy to consider, could this be ADHD? And we're bombarded by marketing, whether it's from the pharmaceutical industry or these private clinics. And so the pitfalls of this are taking on an illness identity, and taking on a diagnosis can be a very useful thing. As I mentioned, I do it often, and it can be very helpful. Kirsty described some of the positive experiences from this, but it can be also limiting when we think of ourselves as having an illness, especially when it's unwarranted, and the interventions can be harmful. We might miss out opportunities in terms of having other addressings, other issues that could be contributing. And if we're all flooding our public health system, or even the private for that matter, because we think that we are diseased in some way or another, it can overwhelm resources and make it more difficult to provide the care for the people who especially need it. I think I'm the only speaker who stuck to 10 minutes, actually maybe Kirsty as well. I will end it here and happy to entertain some questions and participate in the discussion. Thank you.
Great, well done, Elia. Thank you. Can you stop sharing? Thank you. Let's get all the speakers back. Thank you very much for that. And let's get Alison back as well. What I know we're running slightly over time, but what we'll do is let's take a couple of questions for the panel. Alison's still there. And then I want the panel to be ready to give a 20-second, not 20-minute, 20-second sort of final thought from each one of the panel members, 20 to 30 seconds. Okay, Alison, a couple of burning questions.
Well, I think let's go back to the pros and cons of a neurodiversity diagnosis, or rather discourse. And there's too much focus on the individual and not enough thinking about the whole disability movement, which I think Edmund was sort of referring to, and how that changed people's perception of needing to change the environment rather than the individual.
So what's the precise question there, Alison, for the panel?
Pros and cons of a neurodiversity discourse around ADHD.
Okay. Who'd like to start with that? Elia.
Maybe he's on mute. Are you on mute?
I just unmuted, hopefully. I think the pro was outlined beautifully by Dr. Sonuga-Barke, that is in terms of becoming accepting of people rather than pathologizing them. And, you know, it's interesting when we think of ADHD as the thing we're talking about today. You know, what I find often helps with what the diagnosis brings in terms of benefit is the person, especially a younger child, not being labeled as lazy, scattered, you know, in terms that are value laden, and makes the person start internalizing a negative view about themselves. However, can we accept the person regardless of diagnostic label? And I wonder sometimes that, you know, diagnosis labels change over time in terms of their negativity that they involve. And right now, perhaps the term neurodivergent is more accepted than an alternative term, but it might, unless we become more accepting ourselves more fundamentally, it won't be long before neurodivergent starts used in a derogatory, offensive way as well. So I'll leave it at that.
Okay, thank you, Edmund. We've still got you. Before you're, I think everybody should unmute. You're happy.
I'm sorry, I was muted. Yeah.
Yeah.
No, it's a complex issue. If you notice, and I'm torn between the fear of utopian visions, which often the neurodiversity movement slips into. And the truth is that environments that are forgiving or supportive of people with ADHD can be manufactured in certain settings. It's very difficult to manufacture in a big bad world. And so if you notice within my arc of growth, the second to final, I forgot what you call them, second to final element was resilience. And yeah. I do think it's not just about acceptance or valuing, it's actually promoting resilience so that people with ADHD can function in worlds that aren't in environments that aren't sympathetic to them. So I would say.
Okay. Would anybody else on the panel like to comment on this? Anita, and please, panelists, please unmute. I think it's fine to unmute so you're ready to speak when I come to you. Anita.
Edmund and I have written on this, and I think we need both concepts. I think that either or is perhaps not helpful. So for some purposes, diagnoses are helpful for clinical decision making. A lot of families and individuals find having a single diagnosis rather than, i.e. ADHD rather than, and autism rather than neurodivergence, helpful to know what sorts of support groups they can join, etc. But I also think the neurodiversity movement is really important in terms of acceptance and optimizing people's functioning. And in a way, that is what our clinical work is actually optimizing functioning in different ways. But I don't think we can just dispense with one or dismiss the other.
Okay. Anyone else before we take another question?
There's a journalist for the New Yorker, Rachel Aviv, who has written about mental health diagnoses, I think very insightfully. And although I think her work is very nuanced, it sort of can be boiled down to this one statement that I found very powerful and which I actually use now clinically with families. And she says that when it comes to mental health diagnoses, there are stories that save us and there are stories that trap us. And I think it's important to have a transparent conversation with families that if we give a diagnosis or if we think of you as being neurodivergent, is that a story about yourself that saves you in some way, that helps you understand yourself in a way that is helpful and meaningful? Or does it trap you? Does it kind of confine you to seeing your identity through a particular lens that is actually limiting? And I think the answer to that question is obviously going to be different for different individuals, but I think raising the question of what is the meaning of the diagnosis and how does it affect your view of yourself, I think is an important one that we as mental health practitioners should not shy away from.
Okay, thank you. I think we're realizing, if we didn't already, why this is a perfect topic for a known unknowns webinar. Alison, another question, please.
Well, this is a common question for lots of disorders, really, and it's about boundaries. So if ADHD is a continuum, should, and given scarcity of resources, should we be seeking to diagnose everybody or only diagnose those with more severe symptoms? So it's probably coming back to Anita about this boundary question.
Thank you. Anita.
I think it's an interesting question, and yeah, I think for me well, in terms of the epidemiology, there doesn't look like a sudden cut point where people look really different with ADHD. So that's the logical thing. There isn't a tight boundary as such. But on the other hand, some of the intervention, there aren't consequences to not having a diagnosis, to making a diagnosis as well. So having the label, the psychological impacts of having a label, the meaning of the label if it becomes so broad, and also the risks, benefits of different treatments. So particularly when it comes to medication, one would want to be really careful about diagnosis, because you don't want to sort of, your risk benefit ratio starts becoming more problematic. So yeah, I think it's an interesting question, and I don't think we know the answer. I mean, maybe our thresholds do need to change. In modern days, we don't know that, but at the moment, we're sticking with what we've got, at least most clinicians.
Thanks. I'm going to ask Stephen. Stephen, your focus was diagnosis. What do you think of this? And I'll ask Kirsty whether it's helped having a diagnosis. Stephen. Steve.
You asking me?
Yeah.
So I'll make a quick comment. Most of you are competing with a delayed cocktail hour. I'm competing with my late morning appointments that start in 10 minutes.
Okay,
so
we'll just take this.
If I could have a moment to cross-cut a number of questions and comments that people have made. I found this really fascinating. Number one, the MTA's primary outcomes were pre-selected as the symptoms of inattention and the symptoms of hyperactivity and impulsivity. If we had been smart enough to pre-select other outcomes like friendships and peer status, reading and math achievement, improved parenting skills, and internalizing and externalizing comorbidities, Connors et al. 2001, an alternative outcome analysis, showed very clearly that only the combined medication plus behavioral psychosocial condition led to significant improvements in the other 5 beyond ADHD symptoms. So in some ways, the choice of primary symptom outcomes has misled the field for the last 23 years or more into thinking that medication is the only thing that helps with ADHD. If you want quick symptom relief, there's nothing like a stimulant if you can tolerate the side effects and find the right one. And of course, with precision medicine, which we're lacking, we don't know which the right one is. So it's a lot of skilled practice on the part of doctors to find the right med and the right dose. But for impairments beyond ADHD symptoms, adding organizational skills, not the ABA from some of the comments, coordination with teachers, better reward programs, having people fulfill their potential with, as Barclay pointed out, fixed cues rather than assuming that everyone can manage time budgets well. Number 2, just last week, Molina et al., I was a co-author, published long-term findings from the MTA showing that no matter how many of 8 trillion covariates we put in, there was no long-term risk for greater substance use for the people with ADHD in the study who use medication versus not. You can, I mean, there's always unaddressed variables, but this point was raised an hour ago and just wanted to say that. Third, what about long-term medication effects? Another way of doing this isn't just to look at long-term follow-up to see who stays on medication or not, but to do what the Scandinavians do, have access to every school grade and medical visit and medication prescription in a person's lifetime. And when you look at that series of studies, for the 6-month periods in which adults with ADHD are on medications, their risk of serious accidental injuries is cut by 50%. The risk of attempted suicide or self-injury is cut by 1/4, et cetera, et cetera. So we need different ways of understanding the benefits of long-term medication for people who might need them. Number 4, and I'm almost done, a meta-analysis published in 2020 by Koch et al., K-O-K, looking at male-female differences in response to ADHD treatments. The evidence was pretty underwhelming. There are very much similarities, except that females tend to have, on average, these are girls and women, across age span, more side effects to stimulants than men, and have a preferential response compared to men in terms of the non-stimulants, the SNRIs or the alpha-2 antihypertensive medications. And then point number 5, back to precision medicine.
It's the final one, because I think we've
yeah, the precision medicine is the goal. It's happening in cancer. It's happening in other forms of medicine. The brain is arguably infinitely more complex than most organs or most sets of proliferating cells. But in terms of neurodiversity and in terms of treatment individualization, we still don't know much beyond group averages as to who responds to what, but that's the holy grail. So thanks for my moment for a summary.
Steve, thank you. We'll quickly go to Edmund, because I know he's got to go. We'll continue with final comments now. Edmund, how would you like to wrap up?
Final comment? Oh, golly.
Yeah.
Oh, now you've got me. I
finally through you after
you finally
2 hours.
Me, yeah. Final comment. Resilience. Build resilience. That's what my final comment is. In people with ADHD.
Thank you. Kirsty, I said I'd go to you. Final thoughts, and also about whether it helped you having a diagnosis.
Yeah, it definitely has helped me. I went through a period of hating it, but I have accepted it now. And yeah, it's just helped, and I'm hoping it will help future me as well. I think that I may not have known the benefits now, but hopefully as there's services and things that I can access. And then my final comment is, I think when you see an individual with ADHD, you're currently seeing the masked version. So I had a question about why I take medication as an achiever, but you're seeing me on the top form. You don't see the challenges that go with that. So I guess that's just something to bear in mind.
Well, good. Well, thank you for sharing your top form with us. It's been good. Daniel.
So Edmund boiled down his final thoughts to one word, which was resiliency. So I'll do the same. I think my word would be uncertainty. I think that we need to not only feel comfortable with uncertainty, but to embrace it. And as a clinician, I mean, that is the challenge, but also the joy of doing this work. And I think being transparent with families about the uncertainty and working through what we know, what we don't know, and trying to find a path that is best for them based on what we know. That's the journey. And I think that, as in so many areas of life, it's the journey that is most important. So those are my final thoughts.
Great, thank you. Anita. Is Anita still with us? Perhaps not. And Elia's gone as well. Okay, well, I think we're going to wrap up. Alison, anything final from you before I finish? Thank you. Okay, listen, thank you so much to all our speakers. I think it's been a really fascinating 2 hours. So I'm really appreciative of the time. And we've had some really fabulous comments, actually, really interactive session going on in the chat. So that's been really interesting watching that as well. Where are we at? Well, I think we learned a lot about what is ADHD. We then also learned about what's influencing diagnosis. And I think there's a bit of a debate around whether in certain places there is overdiagnosis, and in other places there might be an appropriate recognition of ADHD. But I think there was the overall sentiment seems to me that there is a drive to overdiagnosis. When it comes to the evidence, I mean, Daniel, you talked about the many uncertainties, that word again, around drug interventions. And so there's a lot more work to be done, particularly to understand the long-term impact of the drugs that are being used. And I guess there was a similar question around some of the psychological therapies that Edmund spoke about, and he spoke a lot about tailoring things to the individual and reframing the discourse in a more positive light. We heard from Kirsty, which I thought was a very valuable and inspirational session. So thank you, Kirsty, for that. And Elia described the impact of social media on self-diagnosis, and then the consequent impact on clinical care. So I think it's been a very excellent known unknown session. I'm grateful, as I say, to all our speakers, to our participants, to everybody who's joined and tuned in and listened to us, to Alison Pollock and to George Davey-Smith for putting this together with my colleague Duncan Jarvis. So we'll be back soon. We're keen to hear from all of you, and if there are any topics that you think we should be covering in this series, please let Duncan Jarvis know. If you have any suggestions, you'll be getting an email from him soon with links to the recording, so you can send them to him there. So that's it for this Known Unknown seminar. Thank you very much for listening. The recording will be available very soon on bmj.com/known unknowns, and I'm assuming it's going to be on YouTube as well, and also there look out for our previous webinars. Thank you again for your time.